A couple cases which have some overlap, which will become clear pretty quickly once we start going through them. Similar to prior conferences, I have not pre-selected anyone to participate today. So if you want to participate, if you want to read the chest x-rays or weigh in with an opinion, either put it in the chat or definitely feel free just to talk via the audio. And hopefully this will be cool. All right, so for the people in the chat, which case do you guys want to start with? Case 1 or case number 2? All right, so Megan's going with 2, Mike's with 2, so we will start with 2. All right. So case number 2 is the case of DK. She's a 36-year-old woman, and I'm just going to kind of summarize this for you. She's coming in with the chief complaint of shortness of breath. She had a recent diagnosis of pneumonia. That's what she calls our ED triage. HPI, multiple days of worsening fever, dyspnea, left-sided pleuritic chest pain, similar symptoms 5 times over the past year, most recently 2 weeks prior when she received doxycycline with improvement in her symptoms. She says she's been diagnosed with pneumonia 5 times in the last year, including a couple of times at Denver Health in the ED. She has a past history of active methamphetamine use. She uses IV meth, but no tobacco or alcohol. All right, so hearing this history in the chat or out loud, what are you guys thinking about? Great. So the UCH residents are saying probably not pneumonia, or probably not one of our typical pneumonias. And I think we say this a lot, but right, the definition of insanity is doing the same thing over and expecting different results. And so if this person's coming in and telling us that they've had pneumonia 5 times, maybe treating her for that 6th pneumonia is probably not the way to go there. So I think that's a great way to approach that. Anyone else have any specific thoughts about this? So let's go ahead then, because I think this is not meant to be the most of the biggest diagnostic mystery right now. So UCH is saying possibly organized pneumonia. Great. So thinking about sort of pneumonia mimics, that's awesome. So let's get right in then to her vital signs. So she is afebrile, 36.6. She's got a heart rate of 116. 118 over 80 is her blood pressure, and she is setting 94% on room air. I'm gonna go ahead and give you her labs too, because you're getting called by the ED to admit this person. So this is not gonna be a secret. So her labs, she has got, I'm just gonna give you the abnormal one. She has a white count of 17.9, hemoglobin of 12.3. Her platelets are normal at 304. Her BMP is basically completely within normal limits. And I will tell you that she's got 2 blood cultures, which are going to be pending. And she has a strep pneumo and a Legionella, which are pending as well. I told the UCH people this yesterday, but go ahead and assume that Legionella is going to be negative. Okay. Do the vitals or labs change your guys' thoughts on her differential so far? Great. So CJ says, anything come back on infectious disease workups for prior hospitalizations? Awesome question. So she has actually never had anything documented on culture. She's never been able to produce sputum during the last few emergency room visits, it looks like. And then per review of records, there's never been a specific organism. So really good question. So it doesn't really help us narrow it down. And then Amelia says, tachycardia, leukocytosis, not a slam dunk for pneumonia. Great. So, there could always be something else going on here. I think, UCH brought up possibly organizing pneumonia, but we're looking into things that mimic our classic pneumonia picture. Awesome. So I think the thing that I'm not trying to hide this from you guys, but we're going to go ahead and show you her chest x-ray because I think this is where the cases will start to overlap. So here's her chest x-ray. And what I want you guys to do is take about 25, 30 seconds to read this. And then it would be awesome if someone could talk out loud and give their read on this. If not, I will ask people to put sort of pretend you're a radiologist and put your impression in the chat. So take about 20 seconds. All right. Do we have any brave volunteers who are interested in reading this out loud? And if not, I'm going to ask people to become radiologists and put your impression in the chat. All right, give people a little bit more time and then I will pretend I'm the radiologist. Great. So Jordan says not hyper missed historical data, but hyper expanded perhaps with question up to COPD. UCH residents are saying a doxy susceptible left lower lobe pneumonia. Megan says hyperinflated with a possible pleural effusion. Great. So I think what you guys are all getting at is you're seeing a lot of rib spaces on the left side. You're seeing a lot of rib spaces on the left side over here. And then you're seeing sort of this kind of layering issue here. And you're saying that maybe there's a left lower lobe pneumonia. And then CJ saying hazy opacity, blurring out that left hemidiaphragm on the left hilar area. Awesome. And so I think what all of you guys are getting at is right where we should expect to see that right hemi or that left hemidiaphragm. We're not seeing it, but we are still seeing really nicely silhouetted that left heart border. And so whenever we see that, sort of the lack of the left hemidiaphragm, but that nice heart border, which lobe are we looking at? CJ already brought this up, but we're looking at the left lower lobe. Right, because in sort of on a side view of that left lung here, that's a terrible view. But right, left lower lobe, left upper lobe. This right here is that left hemidiaphragm. And if we're losing that, we assume that the thing that's sitting on it is affected. And so in this case, right, we're expecting that there's probably something in that left lower lobe obscuring the left hemidiaphragm. Okay, so you guys see this. You've got this history of recurrent pneumonias. What is your next step in her diagnostic workup? Throw that answer into the chat. Perfect. So Mike says CT chest. CJ also says CT. Don't really know what's going on. Megan says CT chest, look for obstruction. Awesome. UCH is asking for HIV and immunoglobulin testing, which is great. I think Corey got in their ear on that one. And Miranda is saying, given history, she wants to look at that CT too. I think that's awesome. So let's go ahead and give you guys a CT here. So I'm going to run through this. This is the patient's lung windows. I'm going to give you guys a chance to see this twice. And then again, I'm going to ask you guys to become radiologists. All right, so let's play that one more time. All right, so what are you guys seeing? You can have you can give your full read, you can give specific impressions. Let me know, what is the abnormality on this scan? Awesome. So CJ says, CJ and Miranda both saying left lower lobe consolidation. Melanie is saying, is that left lower lobe airway even open? And Jordan saying consolidative opacity in the left lower lobe. That's perfect. So you guys combined did an awesome job at reading this. So if we scroll to right here, you guys all called this correctly. So you've got this consolidation. You've got a consolidation right here, right? And what notably is lacking from this consolidation? Like, what are you not seeing? Great. So essentially everyone, the people have come together and said that you are not seeing airways. So you are not seeing any air bronchograms. You're not seeing anything. And so you guys all did a great job. This is consolidated on the CT, but the radiologist called it as collapsed. And so there is absolutely no air in this portion of the lung, that left lower lobe. So then if we go up a little bit higher to Melanie's point, because she read this perfectly, if we scroll to this part right here where we have a positive arrow sign, what you are looking at right here is an obstructing lesion of sort of the more proximal left lower lobe bronchi. And so you've got an obstructing lesion causing essentially complete collapse of that segment of the left lower lobe. So this person on the official CT read, they read this as a questionable obstruction of left lower lobe bronchi. And I will also say this person also had some precarinal lymphadenopathy. So if you're sitting next to someone, take about 20 seconds, and I want you guys to try to name off as many causes as you can think of for airway obstruction or a focal airway obstruction. And if you are not sitting next to anyone, throw into the chat sort of your differential or things that can cause a focal airway obstruction. Awesome. So Jordan says foreign body, bronchogenic tumor, fungal mass. Perfect. Sarah says mass, mucus plugging. Awesome. Give people a little bit more time here, but that's a great place to start. So I really like the way that Jordan broke that down. And so essentially Jordan gave us some sort of big buckets to put everything into. And then UCH comes right out with awesome. So UCH, Jordan, and Sarah are sort of all on the same page. So thinking about foreign bodies, malignancy, mucus plugging, infection, autoimmune stuff, or hamartomas, that's great. And so I think to sort of go a little bit further with what Jordan and the UCH residents just said, let's put this into buckets here. And so we're going to put a benign bucket. Talk malignant. We're going to go foreign body or FB, endobronchial infection. And then finally over here, we're going to talk about something that none of them brought up, and I will add your differential, a broncolith. And so I think what I really liked about Jordan and the UCH residence differentials is, making sure we're not missing anything. And so in that benign bucket, that's where you put your hamartoma. So these sort of aberrant blood vessel growths. In the malignancy category, you're talking about, non-small cell carcinoma, adeno, carcinoid, and then some weirder stuff, which is a little bit less common. Foreign body is pretty self-explanatory, but we'll also include mucus in there. Endobronchial infection. Anyone know the 3 big infections we think about with endobronchial infections? And Jordan already brought up one of them, which is fungal, specifically aspergillus. What other 2 infections do we think about if we see an endobronchial infection? Awesome. So UCH is saying TB, which is definitely on there. And I think I pulled a Rick Perry and said there was 2 additional, but really it's just sort of thinking about fungal and TB. Yeah, so Melanie's correct. So NTM could be on there as well. So we'll put that so I'm not completely wrong. Okay, so for endobronchial infections, fungal, TB, and NTM, and the reason these cause sort of that focal airway obstruction is all of these things produce mucus, which then sort of insipates or blocks that airway and causes distal collapse. And then broncoliths, sort of self-explanatory, but you've got calcified nodes that invade into the airway and cause obstruction. And so, anytime you see someone who has this focal airway obstruction, you get your CT, you look for any clues that could clue you into one of these things. But what do we really need to do with this CT result and this differential? Great. So UCH, Melanie, Sarah, everyone is saying bronch, which is perfect. Yeah. So we absolutely need to bronch this person. So in sort of an interesting turn of events, this person, 2 of our interns, Jack Stacy and Danielle Corella, did a really nice job admitting this person. This person actually left against medical advice and said that they wanted to get this taken care of at St. Joe's. And sort of in a surprising turn of events, they actually did get this taken care of at St. Joe's. They left and went straight to St. Joe's and were bronched with biopsies the next day. So does anyone want to take a guess at what this bronchoscopy showed? And just as a reminder, this is a 30-ish-year-old woman with a sort of year-long history of recurrent post-obstructive pneumonias and an obstructing lesion. I like it. Cardiology putting their money down, saying this is adeno. UCH saying broncholith versus hamartoma. I'm not sure ZK is, but foreign body marble. I like it. A year-long marble. Bold. CJ says surprise twist parasites. Unfortunately, this is not a surprise twist in parasites, but all really good guesses. So this person has a well-differentiated neuroendocrine tumor that was approximately 2.8 centimeters. Cardiology says those missing ballots. Yeah, we found 11,000 ballots in this person's left lower lobe bronchi. It's a miracle. So this person has a well-differentiated neuroendocrine tumor, which the pathologist at St. Joe said was a grade 1, which is sort of the least problematic. In an unfortunate turn of events, this person has since been lost to follow-up again. But now has this neuroendocrine tumor, and it's causing post-obstructive pneumonia. So, 30 seconds on carcinoid tumors, we don't see them that often, but the treatment for low-grade tumors, if anyone wants to take a guess here, what would be the ideal way to treat this person? So Mike says somatostatin. So great thought, Mike. She's not having any systemic symptoms, or that might be indicated. Melanie, wedge resection, Sarah, wedge resection. Great. Yeah. So this person, ideal scenario here is resection. And so with resection, her sort of theoretical 10-year survival is about 85 to 100%. So having one of these low-grade neuroendocrine tumors is actually not a huge problem as long as you are able to sort of receive care and get it resected. And they would do a wedge resection with CT surgery. And it would essentially probably be curative in her case. So hopefully she engages with care in the future. Awesome. So that is our first case. And so just to kind of remind you guys what we talked about, this person came in with these sort of post-obstructive pneumonia symptoms. She had this chest x-ray with a left lower lobe consolidation, which ended up being a post-obstructive pneumonia from a carcinoid tumor. All right, so we scroll back in now. We're back to the top here. By default, we will be going now to the first case and this nice floral arrangement. All right, so second case here. SH, she's a 55-year-old woman, chief complaint of chest pain and cough. HPI, she's had multiple days of cough with 1 day of worsening chest and right-sided back pain. History is limited due to dyspnea. Partner has been sick with cough. Past medical history, she has hypertension, tobacco use, social history, 50 pack years, half pack per day currently, no alcohol, and no drug use. And actually, I'm going to pause right there. Dr. Kearns just sent me a message. Dr. Kearns, do you have a microphone available to mention the question you just asked me?
Yeah, I'm not sure, again, not a cardiothoracic surgeon, but oftentimes wedge resections are going to be for like sort of smaller, more peripheral lesions. In this case, they might be able to do like a sleeve where they take out that affected part of the bronchus and like reattach the bronchus. If it was going to be sort of a definitive resection, she probably would need to have the whole lobe taken, just given how proximal it is. So again, not a cardiothoracic surgeon, so I may be speaking out of turn unless Danny ran it past his in-house surgeon before the case.
I did not run it past. I am also not
all right, then I'm going to feel more. Then I'm going to feel more bold about my statement.
Excellent. Thanks, Dr. Kearns. Yeah, so that's I actually was not even familiar that sleeve resections were a possibility. So that's a great learning point. All right, so back to this current case. So SH, 55-year-old woman, she's got chest pain and cough, somewhat similar to our past person, but a little bit older with a 50-pack year smoking history. So for the people of the chat, thoughts on this history? So CJ says the vid, great. Yeah, so this is a question is, would I present 3 COVID cases in the span of 1 month? Probably not, but I like your thoughts. Make me call my bluff here. I think, you know, it's a pretty similar history. And so just getting right into the vitals where this case is really going to be differentiated. So vitals, so this person is febrile to 39.3, heart rate is 120, 136 over 78 is that pressure, and they are setting 86% on 10 liters NRB or non-rebreather. Again, you are called by the ED to admit this person, so I'm going to go ahead and give you some relevant labs here. So their white count is 15.3, hemoglobin and platelets are normal, that BMP is within normal limits as well. A VBG is obtained, which has a 7.4533, that's the PCO2. An ABG is obtained a couple minutes later and is 7.39, 42, 48, with the SPO2 on that pulse ox or on that ABG saying 77%. I will also tell you that this person has blood cultures ×2, which are pending, and she has her strep pneumo pending as well. So, people of the chat, what do you guys make of these this ABG and these vitals? Great. So Sarah says concerning, which is an appropriate way to approach that. Jordan says quite hypoxemic, very sick. CJ says overall she's sick, needs intubation potentially. Great. So you guys are the MICU admitting intern or MICU admitting resident, and he says shunt physiology. So great. So awesome. So Anita, why do you say shunt physiology? Give her a second there. Awesome. So not improving with oxygen. Great. So a really good thing to think about. And Sarah says, how long has she been on the 10 liters? She's been on the 10 liters for, we'll say, 15 minutes or so. That was their initial triage moving to ED. So you're called to admit this person, and you're walking down to the ED. What are you guys going to do? Like, what is your next step here in stabilizing this person? Awesome. So Melanie is asking for an exam, which is great. So I probably should have told you that initially. So her exam, so she has sort of mildly increased work of breathing, and she's got sort of 3 to 4 word sentences. And the admitting resident overall thought that she looked sick. That was their kind of 1,000 foot view of her. So what do you guys want to do to stabilize this person? Great, Bill's asking for a chest x-ray. Chest x-ray is ordered and is pending. So the person is walking at the same speed you are to the room. UCH is saying antibiotics and fluids. Okay, so you've got your antibiotics and fluids. You are working in EPIC. You have ordered antibiotics, you've ordered fluids, and those will take, we'll say, roughly 2 hours to have any sort of effect. Awesome. So Melanie says heat at high flow, nasal cannula first, but may need intubation. Miranda says sounds like high fatigue out potential. Great. Melanie, in your in the chat, can you type out why your go-to here would be heat at high flow nasal cannula? Awesome. Yeah, so Melanie says she has hypoxemic respiratory failure, which is like a great word to put on that. So AHRF, acute, and Melanie says heated high flow nasal cannula. Perfect. So we're going to table that thought. We're going to show you that x-ray that Bill wanted. So try to get this. Give me 1 second here. Oh boy, I broke everything. All right. So chest x-ray. So again, take, so CJ says, we'll think about BiPAP. She's tiring out for additional pressure support. Great. Sarah says right upper lobe pneumonia. She beat me to it. Perfect. So yes, this person has a right upper lobe pneumonia. And so the thing Sarah was getting at, so why does she have a right upper lobe pneumonia? Someone can throw that in the chat. So Jordan is saying, lol, Aztecs. Great. So Jeff Connor's accurate imperfect. Mark Kern says no BiPAP. I'm going to come back to him on that one because that is the purpose of this case. Awesome. So Sarah says right upper lobe pneumonia. Jordan says lol Aztecs. So the reason Sarah said that, right, so we look here, this is sort of that minor fissure on the right, and we are seeing a consolidative opacity above that. And so we are looking at the right upper lobe. And so this person is diagnosed with a right upper lobe pneumonia, which is great. I will tell you that while you were standing in the room, her blood cultures, oh boy, her blood cultures and strep pneumo urine antigen come back positive. So this person has a strep pneumo right upper lobe pneumonia. So she's pretty sick. And Melanie had said she wanted to put her on heated high flow nasal cannula, which is exactly the right thing to do. So before we talk about heated high flow nasal cannula, I just want to show you guys her CT for comparison compared to our last person. I'll play that for you guys one more time here. And so in the chat, what do you guys notice about this CT compared to the last CT? How are they different? Awesome. So Corey's getting sassy with me and says it's on the right, which is great. That's exactly what you want from a coworker. Jordan is saying bronchograms peripheral. Yeah, so Jordan is hinting at this right here. And so he's saying he sees air bronchograms now. And so as opposed to the last scan where it was collapsed and there was absolutely no air there, this is showing you air bronchograms, which is right then when we get into our sort of blood, pus, and water differential. And so really nicely done. So air bronchograms, she's got this pneumonia, and just to sort of recognize that these CTs are somewhat similar, but also different in important ways. Okay, so now to the thing that everyone's talking about. Why was Melanie correct when she said that she wanted to do heated high flow nasal cannula? And part of that is based on this study right here from 2015. And so if we go back to the initial picture I showed you guys, it was a floral arrangement with the letter I afterward. So this is the Floor ALI. I'm not sure if it's Florali, Florali, or Floor ALI, but this study is from 2015, New England Journal of Medicine. And so this study asked a pretty important question, which was, if you take a person who is hypoxic without hypercapnia, so no hypercapnia, which they said was a PaCO2 of less than 45, plus a P to F less than 300, and you randomize these people to heated high flow nasal cannula versus standard oxygen, which they said was non-rebreather at roughly like 10 liters, versus non-invasive positive pressure ventilation. Is there any difference on mortality, intubation rates, sort of any sort of outcomes like that? So they went ahead and took 310 patients in this trial, and they looked at a couple things. So they looked at intubation rate, and then sort of the other big one was 90-day mortality. And so I want you guys to put in the chat your guesses about what this study showed, knowing everything that we know sort of 5 years in the future here. Awesome. So Sarah says decreased mortality with heated high flow nasal cannula. The UCH said heated high flow staved off intubation. And then Jordan says oxygen alone could help correct the high pressures with positive pressure. Positive pressure could increase other complications from pressure-related problems. Yeah, it's a great thought. So Sarah, UCH, and Jordan are all basically right. So what were the intubation rates here? So heated high flow nasal cannula ended up having a 38% intubation rate. Standard oxygen was 47%, and non-invasive was 50%. This did not reach statistical significance, but it was a trend in the right direction. But the big one was 90-day mortality. So 90-day mortality with heated high flow was 12%, standard oxygen was 23%, and the non-invasive was 28%. So lowest mortality with heated high flow nasal cannula at 90 days compared to non-invasive and standard oxygen. And so as Dr. Kearns is bringing up, heated high flow also decreases the work of breathing relative to non-invasive, which is great. And so in the heated high flow group, These patients also had a lower respiratory rate, a higher P to F ratio, and I think subjectively they had increased comfort as well. And so this is something of a landmark trial because it tells us the heat at high flow for people that have sort of pure hypoxemic respiratory failure and pneumonia is really beneficial. And there's also, right, this trend toward increased mortality with non-invasive positive pressure ventilation. And so with that, I wanted to ask Dr. Kearns if he had any additional thoughts on this.
Yeah, so there are a couple like issues why this is super, super important, and some are theoretical and physiologic and some are pragmatic. But before we get to that, like I'd like to toss it back. Who does derive survival benefit from non-invasive positive pressure ventilation? Like where is the evidence to support that? So I'll throw that back to the group first.
Awesome. So Michelle, the people are speaking, Dr. Kearns. So saying COPD, asthma, and cardiogenic pulmonary edema.
Yeah, wonderful. So it really is, and Michael throws in asthma. Asthma, that's actually like an interesting point. So Megan Althoff, one of our second-year fellows, who many of you have worked with, a graduate of the program, actually just published on this, like because there wasn't a huge, robust, like sort of evidence base to support it, but it makes sense from sort of a physiologic standpoint. And so the right answers are cardiogenic pulmonary edema and COPD. There also is a study, and this is like in the olden days of like the late 2000s, that showed benefit in acute lung injury in immunosuppressed patients. Like, so that's something that like shows up, but it's not something we talk about. In fact, we don't even use the phrase acute lung injury anymore. So let's go back to like, the theoretical risk of using non-invasive positive pressure ventilation. So one, the likelihood that this person, and I apologize, I had to step away, so I didn't see the CT scan, either A, has ARDS. I don't know if they had any ground glass over on the left lung, Danny, did they?
They ultimately developed ARDS.
Okay, yeah, so if they didn't have it, the pretest probability that they would progress to that was very, very high. And what therapies like sort of derive or provide survival benefit in patients with ARDS, it's really controlling lung volume. That's like our number one therapy for ARDS, along with treating the underlying cause. So a non-invasive positive pressure ventilation, we may really stretch the lung and encourage large tidal volumes that could be very injurious. So that's one. Two, like what's the time course for people to get better with COPD, exacerbations, or cardiogenic pulmonary edema relative to ARDS / bad community-acquired pneumonia? Like which one gets better faster? Right. Yeah. Perfect. All those answers are great. So COPD, like exacerbations, those can turn around in a timely manner. Like pure cardiogenic pulmonary edema, you could get that person turned around in an hour or two, but ARDS doesn't. And so there's the pragmatic aspect, and this, like for folks that were in the MICU in December, we had some spirited discussions about non-invasive positive pressure as it relates to COVID, both with them and also with our RTs. Like, this is something that's not going to get better fast, and you could wear heated high flow until the end of time and live your life. Like, but non-invasive positive pressure ventilation is very difficult to tolerate for extended periods of time. So just from a pragmatic standpoint, it's not going to work out great. And then the one other thing, and I'm not sure where Danny's going to go with this, but that's really worthwhile about talking about this case of strep pneumonia with that degree of consolidation is what other complications in addition to ARDS are we going to really need to be worried about and monitor this patient for? But I'm going to turn it back over to Danny or address any questions that came up from what I mentioned.
Yeah, awesome. Thank you, Dr. Kearns. Yeah, so Anita says pneumonic effusion and empyema, which is great. And so this person ended up not having an empyema, but to Dr. Kearns' point, I think Dr. Kearns' personal practice, and correct me if I'm wrong, is basically bedside ultrasound in these people almost every day to make sure that there's not a developing effusion or developing empyema there. Awesome. And so that was great. So does anyone have additional questions for Dr. Kearns? So the sort of the last thing I was going to introduce in this conference, one of the things that I was sort of a little bit less familiar with is after we put these people on heated high flow nasal cannula, is there anything we can look at or anything we do to sort of predict who's going to fail or who's going to succeed? Is there anything that you guys have heard of or used? Awesome. So Schweib says the ROX index, which is the thing on MedCalc I have pulled up right here. Schweib, if you wouldn't mind just typing out, what is the ROX index?
Hey, Danny, my fingers are a little too fat, so I type a little slow. But I think you're looking at certain periods of time. I forgot exactly what it is, but you look at initially when they get started on heat high flow, and then I think it's like an hour or 30 minutes, sometime afterwards. And I think you're looking at exactly what settings they're on and also their ABG results, if I'm not mistaken.
Yeah, Schweib, that's perfect. Yeah, that's basically perfect. And so what the ROX index looked like, what Schweib brought up, is it's a pretty easy formula to remember. And so it's the SpO2% divided by their FiO2 as a decimal. So for instance, like, 0.6 if they're on 60%, divided by their respiratory rate per minute. And so that gives you a number which is roughly anywhere from like 2 to 10-ish or so. And so like Schweib was saying, after putting someone on heated high flow nasal cannula, you look at them at time period. So you look at them at 2 hours, 6 hours, and 12 hours. And in sort of the leading pulmonary journal, there's an article that came out a couple years ago where they validated this. But essentially, if you have a ROX index greater than this number of 4.88 at any of those time points, it predicts success of heated high flow nasal cannula. And if you're sort of breaking that down, essentially what that means is you've got a high pulse ox, a low FiO2, and a low respiratory rate, which are all things that intuitively make sense and we look at whenever we put someone on heated high flow. But to sort of have this number 4.88 available, if you were to calculate this, it has been validated in people who have pneumonias. Kind of similarly, if you are at any point at 2 hours less than 2.85, at 6 hours if you're less than 3.47, or if you're less than 3.8 at 12 hours, all of those numbers right there predict failure. And again, these people will probably look sick because what that number implies is your pulse ox is lower, your FiO2 is higher, and your respiratory rate is higher. And so in some ways, it's a pretty intuitive score, but it is interesting, with just sort of three very simple non-invasive numbers that we already have available to us. We might be able to better triage these patients. Notably, this is actually not validated in COVID patients quite yet. If you go on a MD Calc, you can click COVID yes or no when you calculate it, and they're actually using that to try to validate this in COVID. And so hopefully we'll have this data in the future. But for right now, this has basically just been evaluated in patients with pneumonia, non-COVID pneumonia. Anyone have any questions about the ROX index or heated high flow nasal cannula? All right. So that's our board for the day. So what we started out with these two pictures. So the one on the right ended up being an obstruction. The one on the left was a floral arrangement plus an eye, so floral eye. From there, we talked about this case of this really bad right upper lobe pneumonia, which progressed to ARDS. This person ultimately ended up needing to be intubated after failing a very brief trial of heated high flow nasal cannula. And then the second thing we talked about was this patient who had a post-obstructive pneumonia or series of post-obstructive pneumonias, who interestingly ended up having a well-differentiated carcinoid tumor, and hopefully she is able to get back into care and get this thing resected. And like Dr. Kearns brought up, this could be a sleeve resection in which they sort of resect the bronchi and reattach, as opposed to a sort of larger wedge resection. Awesome. Thank you everyone for participating today. I really appreciate it. Everyone in the chat, that was great. And Dr. Kearns just said, my first patient, like case 1, was a pistachio shell, aspirated months prior, post-bronch, quote, I wonder where that went to. Woof. That's the VA. There we go. And if you guys are not familiar with Mike Lee, the former Palm Fellow here, he aspirated a Mentos from a patient's bronchi at the VA about 1.5 years ago. And he ended his conference with just the slide that said the fresh maker, which I still think is the best ending to a conference I've ever seen. But that's it. Thank you guys so much for participating, and have an awesome day.